I want to take a moment to welcome everyone to the kickoff of the His Health Training Series. My name is Amor Amoyge. I'm an Associate Director in Healthcare Access and Health Equity at the National Alliance of State and Territorial AIDS Directors, and I'm the Project Director for the Center for Engaging Black MSM Across the Care Continuum, which we refer to as His Health moving forward. We're so excited to start this training series featuring one of our model programs of excellence in Memphis, Tennessee. We have Andrea Stubbs, who's a manager at St. Jude's Hospital. She is the manager of HIV community programs for the Infectious Disease Division at St. Jude's Research Hospital. And in this role, she serves as a behavioral health specialist, implementing youth-based interventions among minority patient communities. Successful outcomes of her work to date include training and support of community researchers to improve early diagnosis and engagement of youth in HIV care, conducting HIV research within social and sexual networks among Hispanic patient communities, and assessing the safety and feasibility of pre-exposure prophylaxis uptake for young adult men who have sex with men. In addition to Andrea, she will be joined by Brooke Askew, the SMILE Outreach Coordinator, also with St. Jude's Children's Hospital. Brooke is a native Memphian. She has over 9 years of experience as a healthcare professional in the field of HIV education and community engagement, and she's previously functioned as a disease intervention specialist and health educator for Shelby County Health Department for 6 years, currently on team, again, with Andrea at St. Jude's Children's Research Hospital in the Department of Infectious Disease, working with newly diagnosed HIV-positive youth and young adults. Next slide. Great. So just want to take some time to go through the agenda today. We'll first start with a comprehensive background and overview about the His Health Project. So I'll share with you some information about the impetus behind developing this project, the work that we have done with our supportive, gracious funder at the Health Resources Services Administration's HIV/AIDS Bureau. We'll talk a little bit about our mission, values, and goals, and then our final products, which will culminate with the launch of our website this summer in 2016. Then I'm going to pass the baton over to the SMILE team, that's Andrea Stubbs and Brooke, who will give a comprehensive overview on the SMILE Linkage to Care program as well as background information. We'll discuss a little bit about the impact that PHA has on facilitating meaningful linkage to care and engagement for Black MSM patient communities in that region. We'll also talk a little bit about the function of the LTC coordinator, Brooke, within the local health department, and also discuss a summation of community collaborative efforts to facilitate successful LTC outcomes. Next slide. Great, so a little bit about the His Health background. I always like to start these slides or these sorts of presentations about His Health with a little bit on the epi. The audiences we bring to bear are typically well-versed around the epidemics of Black men, but it's always helpful to recap. This is an extraction from our issue brief from February 2015. It's really sort of looking comprehensively to look at the comparison of HIV incidence among Black Americans, so Black men and women, hetero or gay identified or others, and also comparing that to incidence among Black Asians specifically. And we see here a tremendous disparity in this gay men pride. Some time to talk about what our U.S. public health response has been as well, because there is a disparity there as well. This is from Lancet, July 2013, systematic literature review of interventions for Black MSM were reviewed. Out of those studies, more than 50% were primarily focused on addressing risk behaviors among Black MSM patients. So the number of instances of condomless or condom sex, the number of partners you've had, the number of times you may engage in sexual activity or behavior under the influence. Approximately 4 of those interventions were looking at an intervention that was systems-based. And by systems-based, I mean that the target audience included patients, but it also included providers. It also included accessing the way that clinics run. Are they sort of ameliorative and friendly to the needs of the way that young people access care? Is there a social media component involved? Are there opportunities to reduce the amount of time to first appointment after getting a confirmatory diagnosis? And finally, are these studies that were informed directly by Black MSM patient communities? One featured program is out of North Carolina, STYLE, Strength Through Living Empowered. It did all of three of these things that I just mentioned. It coordinated medical social support so that any patient or Black MSM patient who received a confirmed HIV diagnosis was fast-tracked to their first appointment within 72 hours. There was an intense outreach program involved or component involved, reaching out to youth-serving venues in that region, and also a very strong social marketing strategy. For NASDAD, a part of the first steps that we took in developing this project was to continue to augment reviewing and assessing the literature and programs that were out there. And what we started to notice is that there's a definite need for a cultural shift to move from a singular approach of looking at patient behaviors, which is absolutely integral if we're looking at shifting the epidemic, to also looking at what broader systems of care can bring to bear in terms of meaningfully shifting the epidemic among Black gay men. So I want to share a little bit about our mission statement and our values and beliefs, because looking at taking a systems-based approach is looking at a partnership and essentially looking at switching the target audience from being patients to making an intervention that is focused on providers and operators who are sort of working at every level of our U.S. healthcare system. So in essence, His Health is a united community of advocates and of healthcare providers and practitioners and operators who are committed to elevating the standard of care for Black gay men. Our founding principle is that we are operating with the understanding that a meaningful shift in HIV, the epidemic among Black gay men, cannot solely be the responsibility of patients. That's a part of it, but that approach has not worked thus far. We need to approach this as a shared responsibility for patients and providers and stakeholders operating at every level of our nation's U.S. healthcare system. We are clear on recognizing how stigma and how discrimination and how medical mistrust act as tremendous barriers to good healthcare access for Black gay men, and we're committed to doing something about that. That involves restoring trust. That involves bidirectional communication, where Black MSM patient communities are recognized for their fullness and their resiliency, and that providers have a safe space to say, I need answers, I need assistance with finding good strategies, I need help with offering culturally competent care that helps me to check any of my biases, issues, or gaps in my training. So really, we're looking at fostering better communication between Black MSM patient communities and care practitioners and care operators. We're really looking at growing strong and doing it together. Next slide. So in terms of hishealth.org, what are we offering? What are the products? A little bit more background rolling back. NASDAD entered into a cooperative agreement with the Health Resources Services Administration's HIV/AIDS Bureau, say that 3 times fast, HIPAA, in the summer of 2014. Dr. Laura Cheever and Harold Phillips and Michael Evanson in 2013 went into a consultation with the Office of the HIV/AIDS Infectious Disease Prevention Office. And out of that consultation, they were looking at what we have all talked about and seen and what CDC has recently released, right? All of the mounting information that points to the huge disparities in terms of health outcomes for Black gay men compared to other race ethnicities. This consultation has the usual players, the research analysts who are heavy in the field. It had federal experts. It had Black MSM patient communities. Following that particular consultation, HIPAA pretty pointedly asked the participants, what can HIPAA do? And sort of the resounding feedback was, we know what's not working. We need to hear about what is working. There are great strategies out there in the field. They need to have a platform. They need to be highlighted and widely disseminated. And then we need to spark and inspire a different kind of conversation about solutions, because there are things that are working, but they don't have the platform that the disparities research does. And that is really the seed or the seed that sort of planted and began the birth of His Health. So we're really looking to do 3 things with hishealth.org. The first is to identify and evaluate and highlight and widely disseminate promising evidence-based care models and strategies that are doing excellent work with advancing HIV care and linkage opportunities for Black MSM. I want to highlight here that within that, we are offering that in the context of what it is then to also offer holistic and sexual health care services. We are very much aware that from a cultural competency sort of perspective, that functioning as if we are looking at Black MSM patients only in terms of their HIV status can be damning. That is really about offering judgment-free sexual health services that speak to the whole person. It's programs like that that are efficacious and that we're highlighting on this particular platform. The second feature of HISHealth.org that we'll talk about moving through our His Health training series in the coming months is something we're really excited about. We are culminating and creating a cohort of 4 continuing medical education and continuing nursing units that look at specific topics such as sexual health service delivery, mental health services, STD and STI screenings, PrEP, access and uptake, and linkage and retention among young people, as well as transgender health, within the context of what it means to offer that with cultural humility. Those CMEs will be video offerings that are interactive, so a little bit more multidimensional than maybe some of the typical CME, CNU trainings and offerings, and those are accredited by our partners at the Association of Nurses in AIDS Care, as well as the HIV Medicine Association. Those will be live and available on HISHealth.org this summer. So any practitioners or providers that you know of that are looking to, keep their licensure up to date and they want to take part in a really interesting and informative training, this is the place for them to go. Another thing that I want to mention about these CMEs and CMUs, they are 100% free and available to the general public. Wide dissemination and access was very important to NASDAQ and to HRSA, which is why we did it that way. And the third goal of His Health is, of course, to disseminate these trainings and offerings far and wide as possible. Next slide. So now I want to take a moment to pass the baton back to Andrea Stubbs, who will lead this webinar regarding the Strategic Multisite Initiative for the Identification, Linkage, and Engagement in Care for Youth with Undiagnosed HIV Infection, or SMILE. Andrea, please take it away.
Fantastic. Thank you so much, Amaro. You pronounced it. You did all those words with no problem. Brooke and I first would like to thank you all for having us to present on our efforts to improve health outcomes of our young Black gay men in our community. We found nothing but value in working with CBAC and NASDAQ and cannot wait to glean more knowledge from all of the upcoming webinars. I'd also like to take the time to acknowledge our colleagues here at St. Jude and our HIV clinic staff. These are some of the smartest and most diligent scientists and clinicians and caring people I've ever met and have ever had an opportunity to work with. And lastly, I'd like to acknowledge that C2P and SMILE, the research platforms that have allowed us to impact youth linkage to care, are part of the National Institute of Health-funded Adolescent Medicine Trials Network, and that for almost 2 decades has allowed for the creation of a community-level coalition of various stakeholders that share in common the mission of improving HIV prevention and care amongst youth. With C2P being the largest national community-based research study of its kind, it's afforded us inroads into these communities and to be able to effectively link. And here we are in Memphis, Tennessee, doing great things. But before we got into the really meat of our talk today, I wanted to just share with you a little bit about Memphis. Memphis is Tennessee's largest city. We have an approximate population of 938,000. Our city is 52% African American and has a median income of about 46,000. It's most commonly referred to as Elvis Country, and we by far have the best barbecue anywhere. We're located on the bluff of the mighty Mississippi and have for many years been known for our defining moments in history, for our great food and for our great music. But on the contrary, our city looks like an impoverished country seen only by many of us on TV. And that I mean, in Memphis, we are surrounded by poverty. We have limited access, or some individuals have limited access to healthcare services, limited education, and high disease rates among disparate populations. Next slide, please. Memphis has some of the highest case rates of HIV and AIDS in the United States. This is despite advances in treatment, availability of rapid HIV testing, and the increase in evidence-based interventions. Transmission rates among African Americans in Memphis and Shelby County still remain high. We had a low number of estimated new HIV infections of just 433 compared to, say, a large city such as New York being at about 5,300, but an HIV incidence rate higher or equal to those of major urban areas. Our city ranked 7th in estimated new HIV disease diagnosis in the U.S. amongst metropolitan areas. There were approximately 8,100 people living with HIV and AIDS in Memphis, Shelby County. Of the new infections in Shelby County, the majority of these were among the African American community at 87%, were of the male population 69%, and occurred between the ages of 15 and 34 years of age at 59%. 35% of new diagnoses were among men who have sex with men, 25% attributed to heterosexual transmission, and 40% had no reported or identified risk. I'll just add insult to injury here by pointing out that Memphis Shelby also has the highest chlamydia, gonorrhea, and syphilis rates among all metropolitan statistical areas in the nation. Next slide, please. And so Amaro has done a great job of introducing what SMILE stands for. We like to call it SMILE because it is our method, but it's so long and it is somewhat of a tongue twister. But I'll just share with you just on the next few slides about how we were strategic about identifying and not just testing, but linking and engaging our youth into care. Next slide, please. We all understand for the longest time there was a push to increase screening and testing within certain communities. However, we found that testing, though important, left a large number of individuals that were not following up with or accessing medical care. There was a huge gap that was identified in that there was no effective means to link newly diagnosed individuals to care, meaning as testers or those who were on the front line in the community settings, we were not actualizing the full public health benefits of testing when we failed to link those or an individual who was newly infected to care. Bridging this gap between public health and the healthcare system wasn't there, and youth were falling through the cracks. Of course, there were few or some youth that we knew of who knew their status and were somewhat motivated to get into care, but there was nothing being done that was intentional to support the bridging of the gap between the testing side and the medical care setting. So that's where the SMILE program filled the gap, when the entities that are highlighted at the top of the screen, the CDC, the National Institutes of Health, and the Adolescents Trials Networks came together in 2008. The premise was to develop a program that would not only increase the identification of undiagnosed HIV infection adolescent young adults, but to make sure that these young adults were being linked to clinical care centers that were appropriate for youth. Next slide, please. And before I get into the objectives, I'd like to just say that we're not saying that people were not sending them or giving them referrals, but we know for youth, just a referral or a list of clinics to pick from was just not going to work. It's hardly manageable for many of our adults, and so it took some intentionality, a specialized youth-dedicated worker that would say, I will take you, I will help link you to care and walk you through this process. And that's the gap that I think is important to emphasize up front that the SMILE program addressed in many of these communities. Full implementation of our SMILE program was launched in 2010. However, I wanted to point out that implementation looks very differently across the country with our other SMILE partners. And today I'll just be focusing on talking about our efforts here in Memphis and Shelby County. There are specific, no, I didn't want you to advance just yet. Sorry, if you can go back just one more, please. The objectives are to improve the identification of recently HIV-infected adolescents and young adults in the U.S., facilitate practical and meaningful linkage to care at local ATN sites for HIV-infected youth, and to ensure engagement and maintenance of care for HIV-infected youth at local ATN sites. And now we can advance, if you don't mind. Next slide, please. This program targets major metropolitan areas across the country where the Adolescent Trials Networks, or ATN sites, are located. All ATN sites are adolescent-friendly clinics and have providers that are experts in the care of HIV infections in adolescents. And CDC grantees, which are the local and state health departments, were to come together in this partnership with the hope of doing or providing a seamless linkage process. A pivotal piece of in the ability for the local site to function would be to have this privilege of having public health authority, or being extended all rights and privileges as a health department employee. This was the value add, or the key component in order to help with decreasing the amount of time that it takes to link an individual to care, and also contribute to the successes of our program here in Memphis. I'd like to say that, not all of the sites that you see located here on the screen were able to get public health authority, and there were some differences or variances in the number of individuals that were actually able to matriculate through the Linkage to Care program and successfully go through that continuum of care model within the time frames that were set up for the SMILE program. We can advance to the next slide, please. The design of the SMILE and Care for Youth program is to the structure itself is to support a case manager or an adolescent outreach expert, which we call the Linkage to Care coordinator, to provide linkage to and retention in care services for those HIV-positive youth and young adults that are identified through health department testing or any funded test agency that is funded to do testing within our communities. The Linkage to Care coordinator links these youth to care at the ATN sites that are staffed with the physicians that are trained in adolescent health care, and experts that who are very competent with dealing with youth and adolescents with HIV infections. The services of the Linkage to Care coordinator and any clinical care that is provided from the Adolescents Trial Network site, such as our clinic here at St. Jude, are provided to the health department and to those HIV-infected adolescents free of charge. And participation in the SMILE program is voluntary. Next slide, please. Thank you. Through this CDC-ATN collaboration, the health departments work directly with each of the sites to provide the Linkage to Care coordinator, who acts as an agent of the local health department and provides them with the contact information of that newly diagnosed individual at those funded testing sites. And details of those collaborations between the ATN side and the local health department are determined locally via established agreements such as an MOU, and that's how we've been able to operate here in Memphis. Next slide, please. When the funding came for SMILE, it could not have been more perfect, because we had already been working through the Connect to Protect, or C2P coalition, that was established in 2007. And our goal within this coalition was to mobilize the communities to bring about structural level changes. And these are just new policies or programs or practices that address issues that impact the highest risk of youth in our community. Just a couple of the policies that we worked together with our local health department was bringing testing outside of the health department walls, really trying to destigmatize testing in the community. We worked to normalize testing and screening in the local high schools, and this was a great union between our Connect to Protect coalition as well as the health department. We began to build those relationships and build up the trust level, and we had done great work already through the coalition efforts, bringing about new initiatives and addressing various policy and structural level changes to make a difference. So when the SMILE program was launched, it was a perfect marriage where we not only were able to establish linkage to care, but work together with our coalition to address barriers identified for linkage to care in real time. The Linkage to Care coordinator sat in a leadership role, serving as the subcommittee co-chair for Linkage to Care, and that subcommittee's sole purpose was to address barriers that were identified through program and work with the young people to address and remove those barriers in a timely manner. This was a very intentional strategy for our site. It was beneficial for me because I served as the manager for Connect to Protect, as well as I was providing oversight for the Linkage to Care coordinator, and so it was only a natural fit for the Linkage to Care coordinator, Brooke, to participate on the coalition and to be able to talk about at bi-monthly meetings with the coalition about the various barriers or structures that were impeding effective linkage to care within our communities. Next slide, please. And here is a little bit more about, Public Health Authority and HIPAA. We always get a little bit nervous when we see HIPAA and wondering if there is some violation around this or just how to navigate those types of things. And so the privacy rule permits disclosure. It gave the local health department an opportunity to, it allows the local health department to disclose personal health information to public health entities without an individual's authorization for the purpose of preventing or controlling disease, injury, or disability in the community. And covered entities who are also public health authorized may use or disclose personal health information for these purposes. So through this collaboration with the CDC, the ATN, and SMILE, our local site acts together with the local health department to ensure the timely diagnosis and treatment of HIV infection among the youth. Therefore, our local ATN site is acting as an extension of and sharing public health authority. This position is completely consistent with HIPAA's definition of public health authority, and as noted earlier, the details of PHA and a data sharing plan are outlined in the Memorandum of Understanding between our site, St. Jude, as well as the local health department. Next slide, please. Okay. This is just simply a flow chart to help illustrate how our SMILE Linkage to Care coordinator, Brooke, is embedded within the local health department processes. I'd like to turn your attention to the text box below, number 1 at the bottom, which lists out the basic functions of the local health department. Our SMILE coordinator works along with the local health department staff around bullets 1, 4, and 5, specifically conducting outreach to identify at-risk individuals. And yes, that means exactly what it says. Brooke is expected to, and as much as possible, be on the front lines when testers are out there testing so the linkage process can begin immediately. That's not always ideal, but as much as possible that it can happen, we make sure that this does happen. We also would like to ensure that if that is not happening right away from someone being tested immediately and Brooke being on the scene, that linkage to care services are identified right away, or the need for those linkage to care services are identified right away, and Brooke is immediately contacted, and she has a plan to contact those individuals within 24 hours. This document here is a workable, breathable document that was constructed by our staff and the local health department to ensure that both entities would be able to realize successful outcomes for this collaboration. And just as an example, I'll get out of the way, and I'm going to invite Brooke to describe a typical day-to-day working for her. So if you just give us a second, we'll just switch streams.
Hello, everyone. Can you see? Next slide, please. Okay, so I'll start with what a typical day typical day during the week is like for a SMILE or Linkage to Care coordinator. First thing I do is I check in with the lead DIS case manager, as well as the head of the DJJ, which is the Department of Juvenile Justice, for referrals to see if anyone has tested positive or any type of diagnosis that I need to be aware of in the prior day. If none, I head over to St. Jude, but check throughout the day with the health department just to make sure that they have everything that they need from me. If a case does occur, I am contacted immediately, and I head over to the health department where I meet with the client before they leave is my primary goal. If I'm unable to go over immediately, then I do contact the client within the first 24 and 48 hours. And always ask permission from the client if possible, or at least the DIS for home information, locating information for the client. And I try to make the client as comfortable as possible. I'm willing to meet them at home, at a park, McDonald's, or anywhere that makes them feel at ease. Next slide, please. So here is a quote from one of our partner agencies, and it simply states, the Smile Linkage to Care program is a much-needed program in the Mid-South, and the LCC coordinator has created a welcome environment for youth. The Smile LCC program partnership has allowed my team and I to become familiar with the barriers and issues that the youth may face here in the Mid-South as it relates to adolescent-friendly HIV medical care. So I also would like to touch on, before I dive deeper into the SMILE coordinator and the SMILE program, just to let you know some of the expectations of the local health department, as well as highlight what the partner agencies have already said other than this. Next slide, please. Okay, my function as a SMILE LTC coordinator within the local health department. I'm acting as an extension of the local health department with public health authority. Although this collaboration, we have joint goals with the overall health outcome for youth to be linked into care in the most suitable care as possible. The diagnosis of the adolescent or the diagnosis of the youth is also very important. This is a very crucial time for our young people to make sure that they're reached before they leave the health department, especially because so many of our young people are transient. They move from place to place, and as soon as they leave the health department, sometimes it's difficult to locate them. So we call this type of action as lost to follow-up. So we try to locate them before they become lost to follow-up. We often find that they become lost to follow-up in about maybe a minute after they leave. So we have different types of ways to contact the client. We, as a liaison with the local health department, I work with the DIS as well to contact the client, and sometimes we work together as a team. We work to ensure that the youth are linked to a suitable healthcare facility, that they're a youth-friendly provider, or even a provider of the youth's choice. So even if they don't want to come here necessarily to St. Jude, we do give the client the choice and autonomy for their health plan. I work very closely with, in a partnership with the DIS, locating the client as far as even going on home visits, educating the youth, and mainly trying to dispel negative myths and other types of functions for the local health department. Jointly, we ensure that the HIV youth are linked, tested, educated, and available for care, especially in the high-risk communities. The local health department sees any benefit of the collaboration, but at the top of the list, they look at the fact that I'm an additional resource that they have to improve public health outcomes. Next slide, please. Through the SMILE program, we work together, the youth, to make sure that the youth are linked together to a HIV medical appointment within the first 42 days from the date that they've received their diagnosis. The relationship is enhanced by the fact that I'm able to go beyond some of the spaces that the local health department are able to go, and we build a rapport with those youth while we go into those different areas. While educating and improving community attempts of the local health department, the service is often may include treatment. It may include just being the simple point of contact for that individual patient. Between the patient and the collaboration, we work very closly to access youth-friendly case management specialists. We're able to meet them where they are and provide the necessary support that they need for linkage, engagement, and retention in care. Although the SMILE program, we are able to follow through with the youth for a full year after their second medical appointment. HIV medical appointments sometimes can be hard to come by in a timely manner, so we do work with providers to try to get the client linked into care as soon as possible. Another benefit of this partnership that we have with the local health department is as an extension is public health authority. Having access to CareWare database is very important for the SMILE program and for the linkage to care coordinator. While the CareWare services is used as a repository for information so that hospitals, clinics, testing agencies, and community outreach agencies can work together. It includes data of numbers of tests that have been done, who has been notified, the client's personal information as far as for locating the client. And through this database, we do access emergency contacts and simple ways to try to locate their clients between the ages of 13 and 24. As I mentioned earlier, a lot of the clients of that age group are transient, so it's important to be able to contact them as soon as possible. Next slide, please. So when I go to the health department, I also work directly with the medical case manager that oversees all cases identified at the local health department. She immediately contacts me and informs me of all new HIV-positive cases that are under the age of 25. As they are identified and before they leave the local health department is our primary goal. Our goal is also to advise the client of the SMILE program and assist them with linkage to care services within the first 48 hours if we cannot catch them before they actually leave. Additionally, I meet with the public health coordinator, who is the person who oversees cases that are reported to the jail or the Department of Corrections, as well as anyone who has an HIV diagnosis and has not been notified within 30 days. Again, our goal is to ensure that the clients under 25 are linked into care. The ongoing rapport building is an essential part of what I do. We understand that although this is an agreement established by the leadership of the local health department, this day-to-day work is subject to staff changes, is subject to the impact of turnover. So the rapport that I build with the DIS is very important. So it can consist of attending weekly case management meetings, nurturing the relationships that we have with the DIS, and it also, a big part of what we do is include the local health department staff in some of our community activities and some of the things that we do to change the way that things are seen in the community. All right, here's Andrea.
Hi again. We can go to the next slide, please. Thank you, Brooke, for that. And I'll just sort of sum up all that Brooke has talked about, and I didn't want to make it seem like all you have to do is get public health authority, and that's the only thing that you have to do, and that all these cases would magically be linked, but really wanted to create a picture of how this case manager type position has multiple layers that equally contribute to successful linkage outcomes. What Brooke has explained to you really sums up this slide quite nicely. She promotes collaboration amongst providers. She follows the youth for 3 medical appointments in up to 365 days. After engaged in care, she offers case management services and acts as that liaison until official services are established. She also brings barriers that are identified through her work back to our local site, our community coalition for strategizing solutions. And that pivotal key, I think, is also having that leadership role of being the subcommittee co-chair so that in real time we'll be able to discuss whatever barriers that may come about. So, you know, all of what we've discussed so far really, and we can go into the next slide, please, really sort of defines or authenticates that public health authority is essential, and we've shared the benefits of that. Through this collaboration with the health department, it obviously was apparent that there were still barriers to linkage. We were able to see there was a lag in reporting from certain entities through some of the data submissions that the health department was receiving. Patients were still being lost to follow because the data was not coming in on time. So it made it necessary to establish partnerships outside of the local health department to circumvent the lag time with reporting. And so even with public health authority, we had to be intentional about establishing relationships with other entities, such as private providers and major hospitals or even the local blood banks, so that information will come directly to Brooke or our Linkage to Care coordinator. We work to build rapport with agencies first to educate them on the value and benefit of Linkage to Care for youth, the importance of identifying our coordinator as their primary point person with specialized training with linkage. We wanted to make sure that the referrals not only went to the local health department through their normal reporting channels, but also directly to our coordinator. This would help reduce the risk of any individual falling out of care or not being directly linked to care in a timely fashion. And this nice little diagram here really speaks to the success of our Connect to Protect Coalition and the SMILE program working together, because most of these agencies or entities were at the table when we did additional planning with developing new policies, other practices or programs unrelated to linkage to care. They had invested interest in the outcomes of just the total youth and how they could work along with other individuals within the coalition to strategize about prevention methods. So we were very intentional of working with and making sure they had an update about the linkage to care outcomes, who was being lost to care, and why individuals were being lost to care. So this was a benefit that the community coalition was one avenue that was created to have everyone in one place at one time to discuss the various challenges that we were seeing. And I'd just like to share for you one such example of a challenge or a barrier that came about. There was a huge time gap in reporting for newly identified positives that were coming from the local blood bank. From this discovery and discussion with the community partners within Connect to Protect, a nice package of structural change objectives came about as a result. Many of our community partners got together and we did what we call a root cause analysis to address the but why were youth who were going in to be tested or to give blood for money or just give blood. Why is it that if they were found to be HIV positive, there was a 30 to 60-day delay in them actually being contacted or making contact with someone to get into care? Next slide, please. So the problem, preliminary positives were identified at blood banks. These individuals were lost to follow as the blood banks did not have a standardized protocol for individuals to be followed up with or to be linked to care. The local health department records indicated an average of 30 to 60 days in delay of notification for individuals who were HIV positive. So just in short, they received a letter that basically said, and I'm just being very, loose here with the terminology, but it was, your blood work did not come back as we thought it should. You should contact someone at the health department. And there was a generic phone number. And so out of that, strategizing with the community coalition, 3 new policies that were developed. And these policies required the blood banks to inform health departments of preliminary positives at the time they were actually diagnosed to determine how to facilitate this linkage to care. 2 other policies were created, one to establish a standardized contact protocol, and the second one was to specify what to include in the communication with the infected individual. Next slide, please. So the impact that this had, it was able to reduce the referral time. It previously took about 6 months from the first date of test to actually get someone to their first medical medical appointment to within 1 week of a sample of collection. So that was a great value add to the health department as well as to the blood bank, who was actively testing, not necessarily for HIV as a first line, but through the process of donating plasma or donating blood, individuals' blood, it was being screened, and so if they were found to be positive, we now had language to instruct the new positive individual on where to go. We actually had a direct line of contact information for them to go, and we had specific information that would not sort of arouse the individual, but more or less inform them of the next steps to take. There were 17 new HIV-positive individuals that self-reported to the Shelby County Health Department within the first year of implementation of these new policy and practice changes. And we had to be very strategic about this, and I think a valuable part about this strategy is that, again, we had these partners already together, mobilized within our community coalition, and we were able to actively discuss how we can make these changes at the level of the health department as well as the blood bank. Next slide, please. And I'd just like to take the rest of our time, and I think we're probably coming up close to it, the rest of our time to just really share with you some of our program successes, how we've actually been able to operationalize over the last 5 years since implementing SMILE in 2010 to where we are in 2015. Next slide, please, for our data in 2015. But before I do that, I'd like to just clarify program definitions. When we are talking about eligible referrals for the SMILE program, these are referring to individuals between the ages of 12 to 24 years old who are newly diagnosed or have not attended an HIV medical visit within the last 6 months. Linkage to care is defined as attending a first medical appointment within 42 days or 6 weeks after receipt of HIV-positive test results. Engagement in care is attending a second medical appointment within 112 days or 16 weeks after the initial linkage to care medical visit. And retention in care is attending an additional medical appointment at least 30 days and no more than 365 days after the EIC visit. And the way we describe an HIV medical appointment is synonymous with most, but I'd like to just clarify, it's a routine visit where the adolescent attends with a medical provider authorized to prescribe medication. This must be non-emergency, routine, condition-focused exam, and one or more of the following should occur: a CD4 viral load lab draw, or review of the CD4 lab results. There should be some discussion around HIV antiretroviral treatment options, primary or secondary HIV prevention education and counseling, or diagnosis and treatment of complication of HIV and AIDS-defining conditions. Next slide, please. And just a brief data summary for our SMILE program totals. And I'd just like to point out that this data goes through from August 2010, around the time that we implemented the program, up through October 2015. Our SMILE funding for Adolescents Trials Network actually ended in February 28 of this year. And so therefore, in order to be able to seamlessly continue to link individuals along the continuum of care, we stopped taking new patients under the SMILE program in October so that we could be able to see them through to the end of the funding of the end of this year. I'd like to just clarify, however, that we saw this as a value add, we meaning St. Jude and our HIV clinic, and because of the program successes, we'll be continuing this program and have continued to receive referrals from our partner agencies. And that was a positive message that our partners were so glad to hear that we were going to continue this specialized youth linkage. So the total number of cases that were referred to the SMILE program were 655 that met that criteria that I just explained to you. The average number of referrals per month comes out to be about 10, and that does seem like a lot, and it is a lot. We've often said that we needed to clone Brooke just because of the intensity of the case management that it takes to receive a new patient, to engage a new patient, to text a new patient, to assist a new patient, to help get them with the necessary information to get to their appointments, and the process is just tedious but beneficial. And of those individuals that were referred to care, 78% of those were linked. And of those cases that were linked to care, we had 96% of those who were engaged in care. And of the 96% of the individuals that were engaged in care, 90% of those individuals were retained in care. And next slide, please. And just a little bit about the demographics of those individuals. The mean age was 21. And we have the breakdown of gender. 17% were female, 82% were male, and 0.6 identified as a transgender female. In terms of race and ethnicity, the majority of the individuals were Black or African Americans. We had about 3% that were white. And in our other category of 6%, some individuals did not actually notate what their race or ethnicity was, but we also had just a small number of individuals that were Hispanic. And the most likely mode of acquisition, as specified by, or I guess acknowledged by those participants in the program, was male-to-male sexual contact at 62%. We can go to the next slide, please. And really, I just wanted to just say that we've shared with you the importance of public health authority and how it has helped us to glean successes here in Memphis and Shelby County with our linkage to care for our young Black gay youth and young adults. And we've seen this work within our community context, and we so believe that it is something that can be replicated in other communities, and we are actually doing much of that as I speak, because the funding, as I mentioned, has now no longer will continue within our division, but we saw a value in our clinic of the population increased, and we saw the value in having this specialized case management position of youth case specialists to begin that tedious process of linking them to care. We know that from this experience that there was value that the local health department has being the most influential system to engage, and that has helped us to successfully address SMILE linkage to care initiatives in Memphis. We also know that participation on local HIV prevention planning councils such as Connect to Protect helps to formalize these relationships. It serves as one clearinghouse of sorts of all the individuals to come together about 4 or 5 times a year to really talk about those barriers, those structures that may be in place that keep an individual from matriculating through the continuum of care once identified as being positive. This is the only standard process for youth specialized linkage to care, and it's a conceptualized model of success, we believe, so much so that our Ryan White manager here in the city has began discussions with us about duplicating this for those Part A grantees that actually participate in testing within the communities, just because our linkage to care rates for the entire city for adults, anyone over 24, look very different from those numbers that I actually shared with you for the successes for our linkage to care program. And our city wanting to do much better with linkage and to improve health outcomes of all individuals who are positive, this program serves as a value add and a model for other programs to be able to replicate. And we're more than willing to teach them the processes for that. Next slide, please. And I've done a lot of talking, and so has Brooke over this, I just want to say, last 45 or 50 minutes or so. And I'd just like to take a second to pause for any questions that you may have for us. And I'll tell Brooke to sort of slide back in here somewhere.
Awesome. Thank you so much, Andrea and Brooke, for that really informative presentation. I hope everyone can hear me okay. So we can take the time now to take any questions. If you would like, please just enter your questions within the chat box, and we can field them to Andrea and Brooke. Okay. All right, and so we do have one question that's come up. We have one participant who wanted to know what some of the challenges were with getting testing into the local high schools, and how did you overcome some of those challenges?
Sure, I think that's a great question. That was in the early days of trying to normalize testing in our community. And so the challenges, and I'd have to just point out where we are located in Memphis. We're in the Bible Belt. And although the schools are not a faith institution, they mirror each other quite a bit. And so there were very strong convictions or beliefs that testing or HIV or just sexual health should not be something that we're discussing in schools. And so the challenge that we sort of met was from some of the adults, leaders who are the administrators that were leading the classrooms or leading some of the programs that did not want to have the discussion. We found after doing some education, and this took some time, that the testing took over 2 or 3 years to get the testing done in the schools. But it took a lot of buy-in, it took a lot of courting of administrators and teaching and education about the importance of sexual health. And if we had a healthy student, then we'd also have a student that would do well in an educational realm. And so we sort of took that platform and we used every resource that was within the community coalition. If there was someone who was married to an administrator, we made sure that we gave the right speech to that individual so that they can do the talk at home about the importance of having these messages within the school setting. We also use hard data. We knew that our community had high chlamydia, gonorrhea, and STD rates. We were number 1 for 15 to 19-year-olds, and this has been consistent over these years. And so when we did talks, we always used the hard data. The data was our driving point. We also had high teenage pregnancy rates, so we referred to those as well. And we made the case for having talks about sexual health education. And over time, we sort of built in around National Observance Days the importance of allowing us to test. And with this testing model, some of the principles on those National Observance Days would allow us to come in, do a quick message about HIV, why we were talking about it around World AIDS Day or around National African American HIV and AIDS Awareness in February, or National Testing. And so those principals would actively be engaged in an oral swab. And so that sort of opened the door for other individuals to want to participate. We also asked the students, what did they want? And what we found was that they wanted this not for the incentive, but they wanted it because they also understood that STDs were running rampant within their circles and within their social circles and sexual circles, and they wanted to be checked. And so that's how we sort of normalized it over a couple of years, doing the basic education, getting the buy-in and support from key stakeholders, and talking about and capitalizing off the National Observance Days to sort of bring this message over. And really encouraging the health department as well to take testing outside of the walls of the health department. We would go back and say, our youth, they say they don't want to go to those brick walls. They're not coming. It's so much stigma. And so once we were able to help the health department see that they could actually take testing outside of the walls, then it was really no stopping from there.
That sounds great. I've got some more questions coming through. Questions around referrals. One participant asked, where did referrals for the SMILE program come from, and how were those referrals received?
Well, the referrals for the SMILE program comes from any agency that does testing. So that includes the correction institutions, that includes private providers, CBO testing organizations, anyone who does testing is where the referrals actually come from. And so with those testing agencies, we try to partner with them and keep encouraging them to refer the clients who test positive, and why it's important that they refer them in a timely manner.
I'm curious too if any patients bring in sort of their social networks as well in terms of referrals.
Yes, and I would say that's one of the moments that you really feel that this program is really working, when you have a client that you link to care come in and bring their partner or their best friend, or even I've gotten a phone call on the weekend in the middle of the night where a client met someone at a club and the person told them that they were new in town, that they were positive, and where could they go to the doctor. And we did linkage to care that Monday morning. So those are the times that I spoke about previously in the speech, where we go beyond where maybe the health department can go to make sure these people are linked to care.
Sure. I think that wraps around sort of the patient-centered approach and meeting the needs of the patient right where they are. More questions coming through. In terms of the age group for the target population, what happens when individuals graduate from the SMILE program?
I like the term graduate.
Yeah,
once they're of age, at St. Jude is their primary medical care. Once they're age 23, they begin. We begin the whole transition to care model, where we make sure that the client understands their diagnosis, their medication, and how to get in touch with, let's say, funders or even other outreach from that point on. And once they turn 24, they go to their first medical appointment to what we refer to as adult care, and then ask them to come back to see us one more time.
How are you able to reach individuals who may know their status and relocate to your area and are in need of services? This participant is asking due to having had a client who recently moved to your area and they're having difficulty sort of navigating the linkage services in that area.
If someone moves into the area, hopefully they will interact on some of the social networking, I guess, I don't know, the little social networking apps, because there are other CBOs that we partner with who do have access to those social networking apps that we don't necessarily, well, the SMILE program at St. Jude doesn't necessarily participate in, and those CBOs or those representatives contact me, and we work together to get that client in to care or get them the services that they actually need.
And I think speaking of that, we harped on something that was another question that someone had around social media and how you may, I'm not sure if you do, but leverage sort of social media networks online to sort of engage patients.
So because of the research, we were not allowed to engage individuals online through social media. However, we do have partner agencies that were funded to do testing and doing social network strategy, doing some of the other testing within the community who are active on certain SNS social network sites. And so they provide that information to us. That's sort of been our conduit. We don't necessarily have, we've not had the privileges to be able to do that just because of the sensitivity around the research and not really wanting to compromise anyone's identity or just the research itself.
Cool. Another participant had a question around partnerships. Do you partner with any other local, with any other state or local health departments?
Well, so I must say that, you know, Tennessee is where we sit in Memphis. We border Arkansas and also Mississippi. And so this metropolitan statistical area is inclusive of more than just the Shelby County area. So it's inclusive of a few counties in Arkansas and also a few counties in Mississippi. And so that partnership was extended to them as well. And so we help to, Brooke works with those individuals to help link individuals who we know that people live in one area, may play in another area, or access resources in another area. And Memphis is the largest city that's closest to Mississippi and also Arkansas. So there's a lot of going back and forth across the county lines, and we absolutely partner with the departments of health in those counties in Arkansas and in Mississippi in order to make linkage to care work for those who fall within our statistical area.
Great. And we just had one more question. You had sort of talked about the successes in terms of setting new processes, removing policy barriers, and you mentioned sort of being able to secure that MOU as being a success. There was a question around the process of securing the MOU, and really, was it a difficult one? Was it actually much easier than you thought? Sort of a lessons learned, if you will. What are your thoughts on that, hindsight-wise?
So, I can say now that it was an easy process, but it didn't happen overnight. I think the value in getting the MOU done was that we had already had the health department at the table. And so because the health department was working as our community partner through coalition, through the C2P coalition activities, they were already abreast of what our objectives were. They understood what we were trying to do in terms of care for these youth and young adults who were infected with HIV. They had their finger on the pulse of where the research was going. And so part of our natural planning within the coalition is to talk about projected research that was coming down the pike. And so we started the discussions about 6 months before we asked for a meeting, before we asked to take a meeting with the health department director at that time. The health department director had already given her blessing at the onset of Connect to Protect and had identified key personnel to be a part of the coalition. And so her ear was sort of already to the grind of what we were doing. And so when we asked for the meeting, it was a welcoming invite for our director at that time, who was Dr. Patricia Flynn, to go over to meet with the director of the health department along with the deputy director and myself. And we talked about what the SMILE program would do, and we really spoke to the strengths of the program itself and how this extra personnel, at no cost to them, would actually help with support within their disease intervention team, within their case management and social worker team. So we sold it like that. We always talked about the values, and that's exactly what it has been. Brooke and we had a previous linkage to care coordinator. They were actual values to those teams, never getting in the way. We always made sure that they were out of the way, but always went the extra mile to be a part of their team and help to find individuals and help to make their job easier. So that's what made it a little bit easier. It didn't happen overnight, but just those steps of courting and getting buy-in and support helped to gain their blessing to move forward with writing the plan, communication plan, and the strategies.
That's helpful. It's always good to sort of hear the behind the scenes of what all it took, so that someone can know that it was simple, but there is a lot of prep work, it seems like, in terms of getting the right messengers in place to move forward these sorts of policy changes. I feel like we could talk to you forever. We do have to start rounding out. That was the last one of our, we have one more question coming in. I feel like a radio host. This is great. Okay, this is a really great question around faith and spirituality. This is a really great participant group. We thank you so much for your time and being involved. The question is, how do you engage the local faith community, being that you're in the South, we're in Washington, D.C., but you are sort of squarely in the Bible Belt. What have been your strategies for engaging faith-based communities?
Yeah. So our faith-based community are a very powerful entity in the South. As you said, we are in the Bible Belt, and we also recognize that the faith community was the nucleus of the African-American community. And if we wanted to reach these youth, we needed to be able to meet them at all avenues or all points. And so we began having meetings with leaders in the faith communities who were interested in HIV but didn't have a lot of confidence in being able to teach the message from the pulpit, or not sure how to talk about HIV and STD in their faith institutions. What we were sure about, and this came from most of the pastors and some of the designees that the pastors sent to us, was that they had members or congregants who were ill, who had contracted the virus, who had died from it, and they were tired of them dying from it. They were tired of not being active, them being a passive member of this whole fight against HIV. And so we began to go in and just do educational talks to the youth. Of course, within the confines of the parameters of the faith, we didn't want to disrespect the tenets of the faith communities. We always ask, what can we appropriately share? How would you like us to deliver this? What's too much to talk about? And so before we really started to do a lot of the coalition work, we went to those leaders. We went to those community key stakeholders who were of those faith institutions. We courted them, building those relationships solidly, just actually bartering and saying, here's what we'd like to provide for you, for your congregants, and in exchange, do you think you can help to sort of give us the blessing with some of your peers or some of the other churches and get us an inroads into those communities as well? So we just really, it was almost a door-to-door. Let's talk. can we share, and can we teach, and can we educate? And so from there, we gain the trust of the faith community that we wouldn't come in and just say a blaring message that would disrupt what the pastor or the leader of that faith community was teaching about.
Awesome. And talk about taking a systems-based approach and a grassroots one. That's very, very challenging, and great to hear y'all doing that work. So we're rounding out the hour. Want to thank Andrea and Brooke for kicking off our His Health training series. Just a little bit of information for participants. This series will be monthly. We'll offer about 4 or 5 trainings featuring staff who are implementing the models of care that will be featured on hishealth.org this summer. Our next training coming up is April 15th, Juicing Cultural Competency, Extracting Practice from the Theory of Patient-Centered Medical Service Delivery for Black, Gay, and Bisexual Men, be presented by NASDAQ staff, as well as Angel Brown, formerly of Advocates for Youth. Also want to mention that following this webinar, we will send out a short evaluation. We will also package this PowerPoint presentation and share with you our His Health project overview that has our social media links. We are on Facebook, Twitter, and Instagram. Please feel free to pin us, like us, share us, push button, all the words that the young people use for social media. We're really excited to interact and engage and do this work together. I want to thank again Brooke and Andrea and wish you all a great day. Thanks so much.